Hello, I'm Corey Canelti. I'm an assistant professor and geriatrics pharmacist at the University of Iowa College of Pharmacy, and my practice is at the University of Iowa Hospital and Clinics in our geriatrics clinic. We have a team-based care approach where I work with medical assistants, pharmacists, geriatricians, other providers such as PAs or NPs, and then also we have a social worker on staff. We have a team-based care approach. And today I'm really excited to present deprescribing and alternative treatments to opioids, benzodiazepines, and Z drugs in older adults. But first, I do want to declare I have no conflicts of interest or relationships to manufacturers. I have no financial relationships to companies supporting this educational event, as well as I will not discuss any pharmaceuticals, medical procedures that are unapproved by the FDA. Today, I would like to go over and hope that by the end of this presentation, you'll be able to describe the prevalence of anxiety, insomnia, and pain in older adults, as well as identify the risks to taking opioids, benzodiazepines, also known as benzos, and Z drugs, review practices for deprescribing opioids, benzodiazepines, and Z drugs, as well as identify alternative treatments to opioids, benzodiazepines, and Z drugs. And I'm picking anxiety, insomnia, and pain because these are the conditions I often see in my clinic. And whenever patients come from outside and we have a new patient within our clinic, this is something that we look for in their medication list, the opioids, benzodiazepines, and Z drugs, and have a conversation of at least tapering down these medications or finding alternative therapies for our patients. But first, I would like to introduce the concept of healthy aging. It's something we strive for throughout our lives. It's very popular now in public and population health as well in the medical community. It's the process of developing and maintaining the functional ability enables well-being in older age. This doesn't mean that you have to be free of disability or disease, but it's about creating an environment and opportunities that enable people to do what they want and value throughout their lives. We want to focus on physical, mental, and cognitive health, as well as provide social engagement to have these opportunities. This presentation, I hope, will meet some of the mission, a small portion of this mission of healthy aging. And as you know, your body changes as you age. And what this means is that it processes your medications differently. So a 30-year-old and a 70-year-old will process medications a little bit differently. We have a decrease in your liver function and kidney function, as well as any changes related to illnesses you may have impact the way your body processes medications. And medications will stay in your body most likely longer as you get older, and the risk of side effects inevitably increases. I believe this information is not given to patients often when they start a medication when they're 30 years old to think about what's going to happen to their body in a couple of decades. And so with this presentation, what I hope to do is provide an alternative treatments to many of the medications that may have been started decades ago, and then provide some pointers for deprescribing the medications, opioids, benzos, and Z drugs. And I do want to focus on anxiety, pain, and insomnia because these are often what I see in my clinic. Anxiety disorders are causes of feelings of fear, worry, apprehension, and dread that are excessive or disproportional to the problems or situations that are feared. There are many different kinds of anxiety disorders. There are phobias. It could be from spiders or closed spaces or social engagements, PTSD, panic disorders, OCD, and generalized anxiety disorder. And GAD, or generalized anxiety disorder, is what I see commonly in my clinic. And general anxiety disorder, also known as GAD, is something I commonly see in patient populations in my clinic. The DSM-5 has pretty strict criteria of what constitute a general anxiety disorder. For instance, you need excessive anxiety or worrying more days than not for at least for 6 months about a number of events and activities. The individual needs to find it difficult to control the worry, and it can't be attributed to another medical condition such as hyperthyroidism. And GAD, you need at least 3 of the following 6 symptoms, such as restlessness, being easily fatigued, difficulty concentrating, or your mind going blank in certain situations, irritability, muscle tension, and sleep disturbance. And lastly, the anxiety warrior physical symptoms, they have to cause clinically stressful or significant distress or impairment in social, occupational, and other important areas of functioning. And the disturbance is not better explained by a different medical disorder. And the reason why I want to talk about insomnia today is because they do overlap with anxiety. Many of my patients who have general anxiety disorders or another anxiety disorder do experience insomnia. And the prevalence of insomnia and prevalence of GAD and insomnia in my older adult populations has been reported to be about half, 44 to 52%. There are many other reasons for sleep disturbances in the older population. It could be jet lag, narcolepsy, where you have extreme fatigue during the day and then you fall asleep. This could be very devastating because you could be falling asleep when you're doing an activity such as driving. RLS, restless leg syndrome, where you go to sleep and it's hard to control your legs and they have this feeling of twitching, and so you have to get up and walk around. Shift work, many patients or people will work in the night or over the nighttime and find it difficult to sleep during the day. And then also sleep apnea. And sleep insomnia is one of the most common conditions that I hear in my practice. It occurs when you have trouble falling asleep, staying asleep, or do not feel refreshed in the morning. It can come with daytime fatigue, and other symptoms of insomnia include irritability and sometimes tension, and it affects your daily routine and every other aspect in your life. And it both can have a sleep disturbance and daytime symptoms. There is a short-term versus a chronic insomnia. I believe almost everybody in their lifetime will experience some type of short-term insomnia, and that won't be a brief period of being unable to sleep or having the other symptoms that I described earlier. It would last for a few days to a few weeks, probably maybe a month or so. But then many patients do have chronic insomnia. This is a type of insomnia that occurs for at least 3 times per week and lasts for at least 3 months. And some other researchers have defined insomnia, chronic insomnia, for lasting up to 6 months. And about 10% of people currently do have chronic insomnia. And these disorders, particularly anxiety and sleep disorders, are often treated with a medication called a benzodiazepine. You might have heard of this from yourself or from a physician or from a loved one, such as lorazepam, diazepam, and clonazepam. And if you notice, many of these medications have a Z and end with AM, and that can give you a clue that is a benzodiazepine. Or what we call a Z drug, and this is something called zolpidem. And many of these medical conditions will be treated with these medications. When we receive a new patient in the first time in our clinic, when I'm going through the medication regimen, these are the medications I am looking for first because they are high-risk medications in this population. A little bit about the mechanism of action. These medications enhance the effect of the GABA receptor, and they're commonly, again, used for sleeping disorders and anxiety problems. And they do range from short-acting, intermediate-acting, to long-acting. For instance, triazolam, as a benzodiazepine, is more of a short-acting medication. I see this often with our patients with sleep problems and want to fall asleep quickly. And then you have long-acting medications such as diazepam. And diazepam is a very high-risk medication because it can have a half-life up to 50 hours. And what that means, a half-life, is how long it takes for your body to clear the medication, half of the medication from your body. And when we get older, we do have decreased liver and kidney function, and diazepam and benzodiazepines are metabolized through your liver and excreted through your urine. So this can range, the half-life can range up to 100 hours for an active metabolite. So if you stop a diazepam medication on a patient one day, it still might be in their system for up to a couple of weeks afterwards. So this is something we have to take in consideration when we're thinking about tapering off our medications. And then also our Z drugs, they last in your system maybe a couple of hours. However, again, as we age, our body processes medications a little bit differently. So they might hang out in your body a little bit longer, and you might experience more of a hangover effect in the morning if you're taking it for sleep. Interestingly, for benzodiazepines and for anxiety and sleep, there's been good evidence to show that almost 80% of adults, older adults treated with a benzodiazepine therapy continue for at least 2 years. And this may have been just for an acute situation, for a short-term situation. The patient or a spouse experienced a death or a loss in the family and they're prescribed a benzodiazepine. So it was meant for very short term. However, 2 years later, they might still be on this medication. Is because many times it causes dependence and it's very difficult to get off of these medications once you start these medications. And multiple studies have shown and evaluated the association between benzodiazepines and falls are devastating in older adults. And exposure in community-dwelling older adults have been associated with several negative health consequences, such as taking benzodiazepines has been associated with worsening depression, cognitive impairment, as well as physical functioning. Again, we have the serious side effects of the benzodiazepines and Z-drugs of drowsiness and confusion. I've heard patients complain about constipation, dry mouth, and difficulty urinating on these medications. And they might attribute constipation, dry mouth, and difficulty urinating just as a natural aging process, when actually it's a side effect of a drug that they're taking. It can increase the risk of falls and hip fractures, and they are common causes of hospital stays and deaths in our older adults. And it can increase the risk of car accidents. And this may be motivation to talk to our patients because they want to stay independent, maybe in their house or assisted living facility, and they do have driving privileges. And then taking off or tapering off these medications might help them stay independent. The risk of dementia in long-term benzodiazepine users has been evaluated. There was a newer study that came out just this year. It was a meta-analysis, meaning that they pulled 10 studies and they looked at the outcomes and to determine the relationship between long-term usage of benzodiazepines and the risk of dementia. And what they found was pretty significant. They found that the relative risk for developing dementia was about 1.5 times in patients taking benzodiazepines versus patients who did not take benzodiazepines. And then also the risk of dementia was higher in patients taking benzodiazepines with a longer half-life. This wasn't significant, however, there was a trend. What was significant was how long you took your benzodiazepine. If you took it longer, you had more of association of developing dementia. And switching to pain in older adults, this is another very common condition. I hear concerns for my older adult population when they come see me in clinic. There's many different reasons why you might have pain. Spinal stenosis, fractures, urinary retention, constipation, fibromyalgia, oral dental sources, post-stroke syndrome, many different reasons why you might have pain. And this is why it's great to have a great history of the patient and to ask how long it's been going on, the symptoms, the severity, and anything they've tried to make it better or what makes it worse. Many times I have my patients fill out pain diaries to see what has made it better, made it worse, and when the pain is actually happening. Is it during nighttime or is it throughout the day? And that way we can really pinpoint of maybe an alternative treatment to an opioid or a prescription medication for their pain. Pain is very important to treat because there are pretty devastating consequences of pain. For instance, sleep disturbance, functional decline, depression and anxiety, polypharmacy. Interestingly, it's very important to know why our patients are experiencing pain because we might misdiagnose the pain and then just prescribe a different medication. For instance, one of the reasons recently I had a patient come into my clinic and they had previously from years ago, they had pain in their lower back and pain in their abdomen, and they were prescribed an opioid medication, and it wasn't really clear why they had this pain in their back or their side. And so they've been on this opioid medication for maybe 10 years or so. And what was happening is that they had chronic constipation. So this patient was prescribed an opioid medication, and then they're also prescribed omeprazole, which was a PPI to help with any stomach issues that might have been occurring. However, what was actually happening is the patient was experiencing chronic, pretty severe constipation. So as you can see, we were just prescribing drugs to help alleviate some side effects from either just underlying condition or just from a medication that was already prescribed. Sexual dysfunction is another consequence of pain. Malnutrition, the patient might not feel well enough to be able to eat. Prolonged hospital stays, they can have challenging behaviors, particularly in our patients who are living with dementia, because they are unable to express that they're experiencing pain, so they might be a little bit more aggressive to caregivers. Increased hospital utilization and even lawsuits have come about from consequences of pain. The prevalence of chronic pain in older adults, it really varies depending on the literature that you're looking at. It's widely cited underlying disability among older adults, and it considerably ranges. I found between 27 to 87 or 86% of older adults will experience pain, and there is good evidence to suggest that it does increase with age. And pain, many times, is treated with an opioid. An opioid is a hydrocodone or an oxycodone, as you may have heard of before. Unfortunately, many times, too, that these medications are in combination with another medication, such as acetaminophen or ibuprofen. And acetaminophen and ibuprofen are widely available over the counter. So if a patient is already taking acetaminophen over the counter and they're prescribed a pain medication that is a combo medication, such as hydrocodone with acetaminophen, they might be taking too much acetaminophen past the 3,000 milligrams or 4,000 milligrams, which could be harmful for your liver. However, so you have pain medications that are just devastating with their side effects for the opioids, and then you also have them in combination with other medications, such as the acetaminophen and ibuprofen. And the prevalence of opioid use in older adults is increasing. Long-term, which we consider using it for greater than 90 days, has increased from 1.8% to 5.4% in just a relatively short period of time. And among these long-term opioid users, older adults age 65 and older consisted about a quarter of those cases. And as you probably know, opioids in the patient population, particularly in our older adults, do have pretty serious side effects. It can cause nausea and constipation, urine retention, and again, this is when a prescribing cascade can come into play when you have urinary retention, so because you're taking an opioid, but now you might be prescribed another medication to help with that urinary retention. So you're prescribing another medication to help alleviate a side effect for one medication. It has serious impact on your central nervous system, such as sedation, mild cognitive impairment, respiratory depression. You might even have increased sensitivity to pain. And then also has cardiovascular and endocrine system effects. Again, opioids, along with the benzodiazepines and Z drugs, do again have this increased risk of falls. And the reason why I keep coming back to falls, because this is a very harmful event when it happens to our older adults. Approximately half of fallers, the people who have fallen, who fracture their hips, are never functional walkers again. And as many as 20% die within 6 months of having their hip fracture. So it's really important for us to figure out if a patient is taking opioid, benzo, or Z drug, and how to prevent them from experiencing one of these side effects, particularly a fall. And deprescribing is one way for us to slowly taper off the medication, either to reduce the dose or just completely get rid of that medication. It's the planned and supervised process of dose reduction or stopping the medication, which would be ideal. However, that's not always the case. We can't always do that. That may be causing harm or no longer be a benefit. And I think that's a very important part. It is no longer of benefit. It may have benefited a couple of decades ago, but now it may not have any benefit to our patients. And the goal of deprescribing is to reduce medication burden and harm while maintaining or improving quality of life. There are many, many different algorithms out there for deprescribing benzodiazepines. And the one I turn to often in my practice is called deprescribing.org. It is developed by researchers and clinicians from Canada, and they have many different resources on their website. They have algorithms, they have brochures that you can hand out to your patients. brochures that look at empowerment. They have been studied pretty rigorously in the literature, and those resources are also available online. And when we deprescribe benzodiazepines, it's very, very important to go slow. I know we've heard this over and over time with our older adult patients, is just to go slow with the prescribing and deprescribing components of it. But for a patient, for instance, I had a patient who was on a benzodiazepine for over 10 years, and it took about a year for my patient slowly deprescribing over time to get to the minimal dose that she was comfortable with. So it can take weeks up to months to get these medications off our patients, or even wean them down to a lower dose. And one of the reasons why I like deprescribing.org is that they have alternative treatments listed on their algorithms that can be helpful for providers and for pharmacists to recommend these alternative treatments to our patients. And for deprescribing opioids, there are a few deprescribing algorithms and websites online. For instance, I go with the CDC. They have a great pamphlet of how to deprescribe opioids, and if a patient is taking one type of medication, how you can calculate it into a different medication dose, and then how to slowly titrate those doses over time. And it also goes through follow-up. I believe follow-up is a very important process of the deprescribing process. And these are all widely, freely available online. Monitoring during the deprescribing process, I think, is one of the most important parts of the deprescribing process. When I start tapering off or deprescribing the medications in my patients, I follow up at least weekly in the beginning, or maybe every other day with my patients, just to make sure they're not experiencing any side effects, or if they have any problems or confusion with the medication tapering plan. And then also, I want to make sure they're not supplementing with another substance. For instance, are they using marijuana for their pain, or are they using alcohol for anxiety? The goal is for them not to start supplementing for something else that could cause also serious side effects. And withdrawal symptoms, I want to make sure that they're aware of the withdrawal symptoms, but to make sure they're manageable. And if you're looking down here to this one excerpt that I took from the literature, it shows that how quickly the onset of withdrawal can be. If you're taking a short-acting opioid medication, it can be from 8 to 12 hours you start experiencing withdrawal symptoms. If it's a long-acting medication, it can be up to 1 to 3 days. So monitoring and following up with our patients is very important, and depending on what medication they're taking, really dictates when we should be following up with our patients. One of the things I've seen often in my clinic is sometimes people want to deprescribe or discontinue it way too fast. That is highly advisable because they might experience insomnia, anxiety, or nausea, and the tolerance, particularly for opioids, your tolerance for opioids will decrease as you cut down your dose. So this is very important if you're at risk of overdosing if you go too quickly and then you want to jump back up to your original dose. So you are at risk of overdosing. For instance, if you're on 100 milligrams of some medication and then you get down to 50 milligrams of a medication and you feel like you have withdrawal symptoms, a patient might be inclined to go back to the original 100 milligrams that they were taking, which is double the dose at the 50 milligrams they were taking. So you are at risk of overdosing and having serious side effects. And this is something that I see a lot of times with my patients, and that they want to be able to cut the remaining medications that they have so they don't have to buy a new prescription. However, if they do want to cut a slow release or a controlled release medication, I would have highly advised to consult with a pharmacist first, because many of these medications cannot be cut. And so maybe a new prescription needs to be prescribed to the patient. There are available resources. This is a great little table that I pulled from the existing literature from the FDA, again, the CDC, and then Ontario and Canada is pretty progressive with the opioid deprescribing and other deprescribing medication algorithms. This is something I generally use in my practice. We're piloting this in our geriatrics clinic, and this is just one of the examples that I had. I developed a schedule And in collaboration with one of my colleagues, we developed a scheduling tapering where this is an example of a lorazepam taper. I had a patient who was on lorazepam just for a few months. However, it was time to get them off this medication. And as you see, week 1, it might be hard to see, it's a little bit small, but I'll go through it with you. So week 1, they were taking originally lorazepam, 1 tablet in the morning, 1 tablet in the afternoon. And what we did for the first 2 weeks was have a half tablet in the morning and then 1 tablet in the evening or the afternoon. And then after a couple of weeks, we decreased that even further to 1 half tablet in the morning and 1 half tablet in the evening. And then a couple of weeks again, we decrease this even further. And as you can see, it does take weeks sometimes for these medications to get off. If a patient was taking a benzodiazepine for maybe decades, this is probably too fast of a taper. I would recommend of doing a half tablet to 1 tablet, half tablet in the morning, 1 tablet in the evening for maybe a few weeks until they become used to that medication regimen and then timing. And then once the patient feels comfortable, they're able to decrease it again. And now I want to focus on some alternative treatments that I have worked with my patients over the years I've been in our geriatrics clinic. And many of these might be, you know many of these. However, I think it's great just to have a comprehensive list and to go through them again. First and foremost, I go through my patient's diet. I recommend for them to avoid fried foods, maybe fatty foods, and many times I found in my patient population it's very hard to digest. They might experience constipation, diarrhea, and then when you're experiencing those symptoms, it's very difficult to not be anxious or to not be experience depressive symptoms. And so having a great diet is one of the first things I counsel my patients on. And then also alcohol. Alcohol dehydrates your body. It might help you put you to sleep, but it doesn't really help you stay asleep. And to drink plenty of water, but also watch when you drink the water, because if you don't want to drink it too close to bedtime, you might be waking up throughout the night to go to the bathroom. And many times my patients will be drinking, they feel guilty because they don't drink enough water during the day, so they drink a lot at night right before they go to bed, and then they have to wake up 3 or 4 times during the night. And this again is a fall risk because you're groggy, you might have a cat or a dog sleeping with you, so you might trip over your cat or your dog. And it places the patient at a fall whenever you can just easily, hopefully throughout the day, spread out your water, drinking your water at different times. And avoiding caffeine, it does give you jitters. Sometimes this might be hard to avoid, but don't taking it too close to bedtime. And sleep hygiene, we'll go through that a little more in depth in a few slides, but sleep hygiene is critical for all three, for pain, anxiety, and insomnia. And taper and switch medications. Many times what we've done for taper off a anxiety medication such as a benzodiazepine, and the patient might have underlying depression, and so we might taper off the benzodiazepine and start a medication called sertraline, which can help with depression and or anxiety. And then many times I will talk about melatonin, which is available over the counter. It's available over the counter in many, many different strengths. I've seen it from 1 milligram to 20 milligrams. I generally recommend patients starting between 1 and 3 milligrams at night, taking maybe half hour, 45 minutes before you go to bed. But this is widely used over the counter. And then watch over-the-counter medications. Just because you think you might be taking something for pain, a Tylenol medication. However, many over-the-counter medications do have other ingredients with them, such as diphenhydramine, and that can cause some serious side effects such as falls, constipation, as well as urinary retention. So talk to a pharmacist if you're going into a community pharmacy and you're not sure, bring up the box to the community pharmacist and they can look behind on the box to see what exactly medications are in that tablet you're about to take, and to make sure they don't interact with anything else that you're taking. And for my patients, I talk about relaxation techniques like stretching, yoga, having a massage, meditation has become pretty popular, as well as Tai Chi. There are classes I know around us in senior centers that offer Tai Chi or meditation classes for older adults. Exercise. This can be a double-edged sword almost, just because if you have pain, you don't want to exercise. And so just little steps at a time. And it doesn't mean you have to go run a marathon. However, what I suggest, if you're just walking up and down the hallway, if you're in a nursing home or assisted living facility, or if you're driving somewhere or riding somewhere with a loved one, park further away in the parking lot, and it forces you to walk up to the store. Talking to a therapist, I do refer a lot, or joining a support group. You might not have a support group if you're living in a rural area, but a therapist may be available. Both have been proven. There's great research to show, and it helps people work out stressful situations and deal with what makes them anxious. And this has been used for anxiety and depression and pain. In looking at psychotherapy, there are many different types of psychotherapy. CBT, cognitive behavioral therapy, is the one I'm most familiar with and the one I most refer my patients to. Psychodynamic psychotherapy, emotionally focused therapy, and solution-focused therapy, as well as narrative therapy. And looking at psychotherapy, like, who are these people providing psychotherapy? Generally, the person has a graduate degree as well as a license. In each state, likely has their own criteria for a psychotherapist to practice. And many times the states will have a board so you can verify if somebody met those credentialing criteria. And there are many different types of psychotherapists. Psychiatrists are medically trained doctors who specialize in psychiatry, as well as psychologists, who I work closely with in my clinic. Somebody who has a PhD, or what they call a PsyD, and holds a license to practice in psychology. Clinical social workers I also practice with closely in my clinic. They have earned either a doctorate or a master's degree, and they have a practice to clinically work either as a psychotherapist or other aspect of their license. There's marriage and family therapists, and these are usually used for marriage counseling or couples counseling. And again, they've earned a master's degree, as well as they have a license to practice this. Professional counselor, there are many different types of professional counselors. So I would highly recommend looking into the person's background and then verifying their credentials before talking to a professional counselor. And then the pastoral counselors as well, but it does require a master's degree. Cognitive behavioral therapy, again, is something I'm the most familiar with throughout the training I had in my fellowship. It's a psychotherapeutic treatment that helps patients understand the thoughts and feelings that they're going through that influence their behaviors. And this has been used in phobias, depression, anxiety, sleep addiction, and even pain. Generally, cognitive behavioral therapy, CBT, is maybe a short term over a few sessions, ranging from 6 to even 12. However, I do have patients who continually use cognitive behavioral therapy. It's during the treatment course, people learn how to identify and change destructive behaviors or disturbing thought patterns that have negative influences on behavior and emotions. I think one of the goals is to teach the patients, while they can't control everything in their lives. Of course, we really can't control anything or everything in our lives. We can control some things, but not everything. But they can control how they interpret those situations and how you deal with those situations. A focus on changing on the automatic response that you have to a situation that can contribute and exacerbate emotional difficulties. For instance, we have a lot of things that we do with our patients, such as journaling, what triggers these negative emotions, role-playing, you're role-playing either with your therapist or somebody else, relaxation techniques, and mental distractions, such as you're focusing on a different situation than the situation that is giving these negative emotions. There are barriers to psychological treatments. If you're living in the rural area, you might have not enough providers who provide psychotherapy or even cognitive behavioral therapy. There is extensive evidence, though, to support that they do work, such as cognitive behavioral therapy for treating depression and anxiety. So it's very important for our patients to have access to them. Thankfully, there is new emerging evidence showing that telehealth or telephone-based psychological interventions do work effectively for our patients. We call it CBT, telephone-based cognitive behavioral therapy for treating symptoms for depression. There's a lot of evidence that it can help with treating depression if you're talking to somebody on the phone or somebody on the computer. And there's fewer studies, I think, more so with the anxiety, but the available data does suggest that it's more effective at reducing worrying and anxiety than alternative forms of telephone-based therapy. I have a couple of my patients who do prefer telephone-based therapy, either because they can't get out of their house very easily, or they just would like to talk to somebody on the phone or on the computer because it's more convenient for them. And it is reimbursable. Certain practices are reimbursable for the provider, and it can really help with the patient stay adherent to this type of treatment. And thinking of sleep, it's very, very important to think of sleep as an analgesic. There's been studies to show that improved sleep quality results in improved daytime mood, function, and activity. We probably didn't need a lot of studies to show this because you probably experienced this yourself. But there has been studies to show that improved sleep quality reduces pain sensitivity and even can reduce inflammation, which can cause pain. And if you're not having the pain, you might not have the anxiety or the depression that's associated with it. Sleep hygiene is very important. I have a few slides on sleep hygiene because I think we know what we should be doing, but we don't always do it. I'm a prime example of this. It's very important to keep a consistent schedule, particularly if you get up and go to sleep the same time every day on weekends and vacations. It's very important to try to do this as best as you can. And set a bedtime that's early enough for you to get at least 7 hours of sleep. I think this is just a general guideline. Some people might need 8 hours of sleep. Some people might need 9 hours of sleep. So at least give yourself enough time to get the amount of sleep that is good for you. And don't go to bed unless you're sleepy. Some people think that they aren't sleepy, but they should be going to bed because that's their designated bedtime. But if you're not sleepy, you're likely not going to fall asleep. And if you don't fall asleep after 20 minutes, get out of bed. What I usually do if I can't fall asleep after 20 minutes, I go sit in my dark living room, I pet one of my cats, and I just kind of focus on the now and thinking about trying to go to sleep. I don't think about the next day and then busy meetings that I have or the clinics or anything like that because I might induce a little bit of anxiety. So I just start thinking about now and then trying to focus on me, myself, and trying to go to sleep. And then establish a relaxing bedtime routine. It could be drinking a warm glass of milk or even a decaffeinated tea before you go to bed, having a warm shower. I would suggest not exercising too close to bedtime. This is something that I actually did. I did for a while, and I didn't know why I couldn't go to sleep until I figured out that I was exercising too close to bedtime. I had a gym where they had a class at 8:15 at night, and I would go to the class and work out at 8:15, get home about 9:30, and then try to go to bed by 10. I still have a lot of adrenaline going through my body, and it was hard for me to come back down from exercising. So what I did, I switched my schedule and started going to my gym and working out around 6. So that gave more time for my body to relax before bedtime. And use your bed only for sleep and sex. And this will help if you're not watching TV in bed because you want your body to associate your bedroom or your bed only for sleep and sex. And make your bedroom quiet and relaxing. Keep it comfortable and cool temperature. And for the longest time, as I mentioned earlier, I do have cats. And we adopted a couple of kittens and they got really active at night. However, at night they were very playful and they wanted to play, they were jumping around, and it wasn't very calm and relaxing. So for the first few months of their lives, I had to actually take them out of my bedroom and close the door so I would have a good protected time and a quality time for myself to go to sleep. Limit exposure to bright light. And particularly in the evenings, I would say at least 30 minutes before you go to bed. It's very hard in this technological age to do that. We have our tablets, our iPads, our cell phones. We're always hooked to social media. But if you can, limit that at least 30 minutes before you go to bed. And exercise regularly, and maintain, I can't stress enough, a healthy diet, and be particular with what you eat. And exercising, make sure you're exercising more so in the beginning of the day or throughout the day, and not right before you go to bed. And don't eat a large meal before bedtime. It can be hard if you have a busy schedule or if that's what you can only do, because your body, you might feel uncomfortable when you go to bed. If you are hungry at night, you can have a small snack, maybe some crackers or even some celery. Avoid consuming caffeine in the late afternoon or evening. Some patients of mine will not drink caffeine afternoon. In some patients, they're okay if they're drinking it until 5. However, you know your body the best. And then even journaling when you take your caffeine and when you think the effects wear off will help, so you know when to stop taking caffeine throughout the day. Avoid consuming alcohol before you go to bed. Again, it might help you put you to sleep, but does it help you stay asleep? There's good research to show that after maybe you had a couple of drinks, it's good for putting you to sleep, but you're more likely to wake up throughout the nighttime, and then you have to go to the bathroom. And reduce your fluid intake before bedtime. If you feel guilty during the day and you want to just stock up on your water at night, be more cognizant about that and start drinking your water throughout the day. And pay attention to your medications. I find this often. One of the first things I focus in on is if a patient is not having a good time sleeping, we go through what are they doing at night, why they might not have a great time sleeping. And many times what I find is that they're taking their medications maybe at inappropriate times. For instance, a diuretic. A diuretic makes you go to the bathroom. So you want to make sure you're not giving a diuretic before the patient goes to sleep or before you go to sleep. I had a patient recently who was taking hydrochlorothiazide, which is a diuretic, right before they go to bed because it's their routine and that's when they take all the other medications. And so we worked with this patient to look at their daytime schedule, and we just switched all their medications to the morning, which worked out so much better, and they were able to get more restful sleep. And in long-term care or even hospitals, what I try to do is I pull up the curtains during the day because we do have a circadian rhythm. We want to make sure that it's light during the daytime and dark during the nighttime. Keep alarm noises to a minimum. This might be hard in the hospital, particularly if you have some contraptions that are beeping throughout the night. And then also increasing your daytime activity, getting up, having physical therapy, just getting up, going to the bathroom, and not staying in your bed the entire time. Reduce the number of naps throughout the day, and I would suggest not taking a nap after 2 p.m. because you're less likely to fall asleep because you just had a nap maybe at 5 p.m. And I would try to limit those naps to maybe up to 30 minutes. And drink maybe a warm decaf drink at night before going to bed. And again, restrict your food, caffeine, and smoking before bedtime because nicotine is actually a stimulant, and it can be hard, it can make you jittery and hard to sleep. Use the toilet before going to bed. This might be something that we all know to do, but if you're living in a long-term care facility, you might have caregivers who come around and help you use the restroom before you go to sleep. Have regular bedtime and rising times, and avoid waking at night for direct care. And unless we have to give our patients a medication, take a blood pressure, stab them for an insulin syringe, let the patient sleep because they are more likely to have better outcomes when they do have good sleep. And trying back rubs and gentle massages as well is very beneficial. Sleep diaries, and this is how I found out how I can better my sleep, is through a sleep diary. There's a lot of sleep diaries online. If you just Google or even go online for an internet search and put sleep diaries, you'll find multiple sleep diaries. Just pick the one you believe is best for you. And there's multiple things that you can record on your sleep diary, such as naps, how many naps during the day you take, any sleep aids, do you need to take any melatonin, some people might take some alcohol, maybe even a Z drug to go to sleep. Sleep times, how long are you sleeping? Are you sleeping 6 hours, sleeping 7 hours? Times to fall asleep. Do your best guesstimate of how long you think it takes you to fall asleep, maybe 20 minutes, maybe 5 minutes. Number of times you woke up, and duration and wake periods. So if you're sleeping, you wake up, you might be only up for 5 minutes, or you could be up for a couple of hours. That's a huge difference because the way we treat that might be different. Your morning wake time, record that, time you get out of bed. And so this really does work with the sleep efficiency. For instance, I look at sleep time. So if you got 8 hours of sleep, but you're actually in bed for 10 hours, and then you times that by 100, your sleep efficiency is only about 80%. However, the higher you get is the better percent-wise. The lower you get is probably worse. Fatigue level about getting out of bed. Do you feel refreshed? Are you fatigued? Are you really tired? You can set your own 1 to 5 scale, or even a happy face, smiley face, whatever it is. And then also your sleep quality. Do you feel like you did get really good sleep throughout the night? And looking at non-opioid treatments, in general, there are other medications out there and other alternative treatments to help treat pain. There are prescription gels and patches, and many of the gels that we have, maybe a diclofenac gel, will help in the small joints, maybe your arthritis in your hands. I don't see it very useful for maybe the larger joints because it has to absorb through your skin to be able to help. And plus it can be pretty expensive through the insurance. And gels, just one of the side notes that I have is that it's primarily water-based because it's a gel. I've had patients who didn't tie on or screw on the cap very tight, and it does evaporate, and the next couple of days they found that half their tube, which is very expensive, to be gone. And it was because it evaporated. And then we do have patches like lidoderm patches, lidocaine patches that I do recommend often to my providers. And the reason why I like the prescription lidoderm or lidocaine patches is because you can cut them to fit the area that you need. And generally with these patches, you leave them on for 12 hours and you take them off for 12 hours. And so if you have maybe 2 spots in the back, and your back, you can cut the patch in half and put them on those 2 spots that ache the most. I would suggest not using more than 3 patches at one time, and make sure you only have these lidoderm patches or lidocaine patches on for a maximum of 12 hours, and then you have them off for 12 hours. One of the, I think, the downsides of the patches is that if you do have back pain and you have an older adult who can't reach their back, so they might have to have somebody help them get it on and take it off. There are over-the-counter medications, analgesics. We have acetaminophen is the top medication that I recommend to our patients, but we have to be very careful. As I mentioned before, acetaminophen, it seems like they're in numerous products over the counter. You might take a cold and flu remedy and look at the active ingredients, and you'll see 4 or 5 active ingredients, one of them being acetaminophen. So again, talk to your pharmacist, talk to your provider about the right medication for you. Ibuprofen, I rarely recommend ibuprofen because it does have side effects of bleeding, stomach ulcers, and it can interact with other medications. So I rarely recommend ibuprofen unless it's really in the short term. And for our patients who are taking anticoagulants, maybe a warfarin or anything else that might thin out the blood a little bit, or antiplatelet, this can have a severe interaction. And there are over-the-counter lidocaine patches. They are 4% compared to the 5% that are prescription. And these lidocaine patches, read the directions because they're all going to be different, and how long you can keep these on your skin. It might be 6 hours, it might be 8 hours, and you might not be able to cut these patches either, but they are available over the counter. And creams. We do have creams that might work for a short duration of time that are also available during the counter. And we have TENS units. We have prescribed TENS units for our patients, and they found great success with those. The barriers I found for the TENS units, where they're the electrical impulses that are being delivered, is that either they're too expensive, or the little things that you had to, the suction cups that you had to put on your body might fall off. So you had to keep rebuying those little sticky suction cups. And then also, if you have back pain, it might be difficult for our patients to actually put them on the back. So you need, again, a caregiver to help you place those on. And physical therapy. We recommend physical therapy all the time. Either it could be a patient goes for a couple of weeks, and the nice thing though is that it's really tailored to your symptoms, and they'll give you some exercises to try at home. So physical therapy, I highly recommend physical therapy. And again, non-opioid treatments, we have CBT, cognitive behavioral therapy, that has been shown to work for patients. Distraction methods, acupuncture, and even massages will help. There's been, I've seen a lot more advertisements for therapeutic massages, and to make sure you check the background of the therapist, the massage therapist before using that institution. guided imagery, hypnosis. I've seen patients use hypnosis. I'm not too familiar with hypnosis, so just make sure you do a lot of research before engaging in those practices. And I'm seeing a lot more with mind-body stress reduction, particularly with mindfulness meditation, as well as yoga and Tai Chi. Many of these I've seen offered at senior centers or even centers just located around the community. It might be pretty nerve-wracking to go on at first. However, usually they're pretty welcoming to newcomers, and it helps keep you motivated when you do have a social support system there. Mindfulness, just to go a little bit through mindfulness, is that it's the mental training practice that involves focusing your mind and on your experiences, like your own emotions, thoughts, and sensations in the present moment. And many times my patients really benefit from the breathing practices of breathing slowly in and out and really focusing on the now. And when they have a panic attack or an anxiety episode, they will practice many of these procedures, and it helps them tremendously. I had a patient who would visit the emergency department once a month because of anxiety and or depression, and she started seeing somebody who was teaching her techniques about mindfulness and then also breathing practices. And since she has started mastering these techniques, she's been out of the hospital for over 3 years and hasn't experienced an emergency room visit because of her anxiety and or depression. And of course, for neuropathy, for nerve pain, there are prescription medications available, so talk to your provider or your pharmacist about these medications, particularly if you want to taper off opioids or taper off maybe a benzodiazepine. There are some medications that have been shown to help with some neuropathy, such as duloxetine. Gabapentin I've seen used, however, gabapentin does have its own serious side effects of drowsiness, confusion, and even fall risks. So usually I see maybe a duloxetine for chronic nerve pain. And in conclusion, we have a lot of take-home points, and I was really excited to present this because I wanted to bring in my own practices, but then also what the literature has. We know that opioids, benzodiazepines, and Z-drugs have serious side effects. They really do have serious side effects. Again, if you're taking them when you're 30 years old, you might not experience the same side effects as a 70-year-old. Many times when I talk to my patients who've been on a benzodiazepine for years or even decades, they'll tell me that, oh, I don't experience any side effects, I'm doing okay with it. However, they might not be doing okay with it, and it's probably best to try to, if we can, at least reduce those doses, because in the future they might have more concerns or they might have more adverse effects or a fall risk with it. And consider the appropriateness of using high-risk medications. I'm not saying these medications should not be used for anybody. They might be appropriate at times. They might be appropriate, but we need to evaluate that and then also inform our patients the serious side effects associated with maybe the benefits they might receive. Many times the benefits and the side effects are not equal, and the side effects are a lot more than the benefits. And then consult with a provider or pharmacist before tapering medications. This will be very helpful. I don't like my patients doing this on their own, particularly because they might want to just cold turkey and stop a medication. For instance, I had a patient who was on a benzodiazepine, and she was hearing from the news and hearing from other places that her benzodiazepine, I believe it was alprazolam, was bad for you and it can cause dementia, it can cause falls. And she just immediately stopped it. She's been on it for a very long time. So she had withdrawal symptoms, and then she took the medication again, and it was very difficult for her because she was anxious to come back to her baseline so we could taper off the medication. Monitor during the deprescribing process is so critical. We have to monitor. I believe this is probably one of the weakest points that we have in healthcare in general, is monitoring our patients once they leave facility or once they're out of sight, out of mind, and making sure that we're calling our patients, following up with our patients, that we have an open dialogue with our patients, that you can email us or you can call about any situation or problems that you're experiencing. As well as there are alternative treatments available, and there are many, many different alternative treatments. However, we need to be upfront with our patients that they might not have the immediate relief as maybe an opioid. However, over time, they are preferred because they have less serious side effects. I thank you for your time, and I was very excited to present this presentation, and I hope that I really do hope that you have great luck in your practice. Thank you.